Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami with our Monday afternoon Instagram chat. Today's topic is Ovarian Reserve 101. Are my eggs any good? And this is probably one of the most common things that couples and women in particular ask. They want to know, am I fertile? And obviously the answer to that question is more complicated because it involves not just understanding are my eggs any good, but understanding if my tubes are working, my uterus normal, do I ovulate okay, and is my partner's sperm is okay. But if we focus just on the one component of my eggs, basically, there are a couple ways to assess an answer to that question. The single most important thing to understand is that the quantity and quality of the eggs changes throughout life, and it doesn't get better as you get older. It gets consistently worse. And the rate at which it deteriorates, so to speak, as you age varies from individual to individual. The most eggs exist when you're actually a fetus at 20 weeks gestation, and they're in the millions at that point. When you start menstruating in your teens, it's probably about 100,000 eggs in the ovary. And from those eggs, over your reproductive lifespan, you'll ovulate about 400 or 500 of them, one a month for 30 years or so. And then the other ones undergo a process of atresia. And each month, a certain batch of eggs are potentially available to ovulate in that cycle. And in the human species, only the dominant follicle or the leading follicle will actually ovulate, and the other ones are suppressed. In contrast to animals that have litters like dogs or cats, there are multiple eggs that are going to ovulate every month, and you always have high order multiple pregnancies. So in general, the single most determinant of the expectation of is an egg going to be a good egg or not is going to be the answer to the question of how old are you. The older you are, the less good quality eggs that you have, the less number of eggs that are in the ovary. And for the most part, your best quality eggs are going to be when you're in your 20s, less so in your 30s, much less so in your 40s, and very non-existent as far as you get into your later 40s and beyond. The concept is called Ovarian Reserve, and that's just the quality, quantity, the reproductive potential of those eggs. And while it's not a yes or a no, are the eggs fertile or not, it's more of a dimmer switch. As you get older, there's less good quality eggs there. So in general, when you look at younger patients, more often than not, they have good quality eggs. And when you look at patients, let's say, that are in their late 30s or early 40s, some women at that point will have good biologic markers of ovarian reserve, and others will have very poor markers of ovarian reserve. So asking age alone becomes less of a good predictor as you get older, because they fall into different categories of you could be older but have really good ovarian reserve, or older and have poor ovarian reserve. But the biologic markers of ovarian reserve don't override what we learn from asking you how old you are. And the reason that as you get older, pregnancy is more difficult is that even when the eggs work and the egg ovulates and it's fertilized by a sperm and forms an embryo, or the eggs are gotten in an in vitro environment and fertilized in the dish, when the embryos develop, a much higher percentage of embryos are abnormal in older patients compared with younger patients. So the age expected aneuploidy rate, aneuploidy being an abnormal genetically of an embryo, is much higher. In someone age 40, it's about 70% of embryos, where in someone age 30, it's around 30% of embryos. In someone age 35, it's half and half. Half the embryos that form will be normal, half are not normal. And almost uniformly, an abnormal embryo is not going to result in an ongoing pregnancy. It will either not stick, it will stick and then stop developing and you get a negative outcome, or it sticks and you get a miscarriage, and the rare one sticks and you get an abnormal baby. And at age 40, the risk of a Downs baby in any pregnancy is about 1%, where at age 35, it's as low as 1 in 350. So most of the abnormalities that you see in embryos aren't Downs babies. There are other abnormalities that are just non-compatible with a healthy pregnancy and an ongoing pregnancy. So the first thing we do is ask you how old you are, and then we look at some biologic markers of ovarian reserve. The biologic markers come in the form of some blood tests and an ultrasound. The blood tests, the most common one is anti-Müllerian hormone test, or AMH level. This is a hormone that's produced by the cells called the granulosa cells that surround the egg. And in general, the higher the AMH level, the more potential eggs you have in the ovary to work with. It's not a direct correlation, and a good AMH level is going to be in the 2 to 4 range. Women with polycystic ovaries tend to have very high AMH levels, and women with diminished ovarian reserve tend to have lower levels. If you're 30 years old and you have a value 1.6, let's say, that would be a little on the low side. But if you were 41 with a value 1.6, that would be not bad. And so also you have to correlate the AMH level with age, in that the AMH level will normally decrease as you get older. And therefore, it's not uncommon to find women that are 41, 42 with low values. But in women that are younger, despite there being a lot of variation, more often than not, you should see higher values in women with more ovarian reserve or better quality eggs. A good value is anything over 2, and an older woman a value over 1. When we look for egg donors for our egg donation program, we use a minimum of 2 as a cutoff to give you an idea of what we would like to see for a good, vibrant ovary. A value that's low does not mean you can't get pregnant. It just means that you're going to have less of a response to a given dose of fertility drugs. And in women over 35 with low AMH levels, there's been shown a higher incidence of aneuploid embryos compared to those with good AMH levels. The second set of blood tests are measuring FSH and estrogen. That particular test needs to be done between the 2nd and the 5th day of your flow, where the AMH level can be done at any time of the cycle. And with FSH and estradiol, a low FSH and a low estradiol, well, let's say a low FSH meaning under 12 and an estrogen level under 60 is a normal value. If you have a high FSH with a normal estrogen level, then that is a concern of an ovary that doesn't function that well, and it'll have less ovarian reserve. And if you have an FSH that's low with a high estrogen level, then it brings up the concern that there might have been a cyst present at the time that the blood test was done, causing that particular result, or the FSH being normal is less of a good prognosticator if the estrogen is elevated, because an elevated estrogen can lower FSH levels. And the third marker of ovarian reserve is what's called antral follicle count. Doing a pelvic transvaginal ultrasound on the 2nd to 5th day of the cycle and measuring ovarian volume, the height, width, and depth of an ovary, and more importantly, measuring the total number of what are called antral follicles. These are the little black lakes in the ovary that are between 2 and 10 millimeters in size, where the eggs live. You can't see the eggs because they're microscopic, but you can see the antral follicles that are present in that particular month. And there's relatively reasonable consistency month to month. Sometimes there's some variability, but it's unusual for someone to have a low antral follicle one month and a super high count the next month, although the exact number of antral follicles you see may vary. And a normal antral follicle count, or a good antral follicle count, would be 5 to 10 per side. So you'd like to have at least a total of 10 antral follicles, an FSH preferably under 10 with an estrogen under 60 on cycle day 2 or 3, and an AMH level of at least 2. Those things altogether suggest good ovarian reserve, no matter how old you are, you're going to do better with less doses of drugs rather than needing more doses of drugs. Most of these parameters give us an idea of how to counsel you relative to your age. It also gives us an idea of how to alter the dose of medications that we use to stimulate the ovary, particularly with injectable fertility drugs in an IVF environment. And it gives us some idea of what we might expect regarding aneuploidy. It does not answer definitively, will I want to get pregnant, or will my eggs work or not work. You have to look at the global picture. But in general, if you looked at, for instance, an AMH level 1.1, that value in a 35-year-old, although low, is more likely to give us better outcome than the same value in someone who's 42 years old. So at the end of the day, age is the most important determinant, but within any age group, we can use all these other values to give us an idea of whether you have better age expected or lower than ideal ovarian reserve for age. So I hope that's been helpful to you. Again, age, biologic markers for blood tests, AMH, FSH and estrogen, and ultrasound for antral follicle count on the 2nd to 5th day of the cycle. Putting those things together and having a discussion with myself and one of my partners will give you a good idea of where you stand and how we can help maximize your chances of fertility. So have a good afternoon and stay safe. Bye-bye.